Okay, so indicators of kidney function. So the most accurate indicator of kidney function is one that we really can't measure. Glomerular filtration rate, meaning how much filtrate, how much solute is going through all those glomeruli per minute. And normal is 120 to 130 milliliters per minute. So meaning both of your kidneys are able to filter 120 to 130 milliliters through the nephrons per minute. That's an amazing amount of fluid, okay? So that's a normal GFR, but we don't typically measure GFR, okay? We measure other tests and then calculate the GFR. So it's kind of an indirect measurement to get to the GFR. So here are some of the lab tests that we can measure in the blood. So serum creatinine, typically 0.6 to 1.2 is a normal serum creatinine. It's an indirect measure of GFR. It's not as accurate, but it's an indicator of normal functioning kidneys versus abnormal functioning kidneys. So serum creatinine is actually a breakdown product of muscles. So our muscles are continually breaking down at a very minuscule level, and they release some creatinine. And then that gets filtered through your kidneys into your urine. So if your kidneys are weak, your creatinine isn't going to get filtered as well, and you're going to have an elevated serum creatinine. So it's a marker of kidney disease if it's elevated. Blood urea nitrogen, so urea is the breakdown product of proteins and amino acids, typically in the liver, right? So when the body wants to get rid of amino acids, which it doesn't always want to, it wants to often build new proteins, but when it does, there's a nitrogen group in amino acids, and it goes through a cycle and becomes urea, and that gets filtered into or through the kidneys. So BUN, or blood urea nitrogen, is another marker of kidney function, and if it's over 20, it means that the kidneys are weak. By the way, blood urea nitrogen typically goes up much faster in the setting of an acute kidney injury. Okay, so if someone suddenly becomes very dehydrated, or someone suddenly is hemorrhaging, the creatinine might take a day or two to go up, but the BUN goes up very quickly. And that's because amino acids are constantly being broken down into urea, and if they're not being filtered by the kidney, it goes up quickly in the bloodstream. Okay? Creatinine clearance. So I would think of creatinine clearance as very similar to glomerular filtration rate. So creatinine clearance we can measure just using a serum creatinine. Okay? So it's a more precise measurement because what it takes into account is whether it's a male or a female when we do the calculation, the age of the person, and we end up with an approximate filtration rate. Okay, so the creatinine clearance and the glomerular filtration rate are similar, and we calculate creatinine clearances to almost mimic and get close to glomerular filtration rate. Okay, and in males, it's 90 to 139, which is considered normal. In females, 80 to 125. Okay, so it's just a calculation that we can do with a computer that takes the serum creatinine and tells us how much is the kidney likely filtering. Okay, so a decreased creatinine clearance is basically the same as saying a decreased GFR, and it's an indication of impaired kidney function, or it's an indication that there's very poor circulation getting to the kidneys, such as in hypotension or dehydration, or you have profuse diarrhea and you're dehydrated. Okay. When is it increased? Well, there's a few instances where creatinine clearance would be increased. I would focus more on creatinine clearance that's decreased. And when it's decreased, it's an indication of some kind of kidney disease. Okay? And we really start to look closely at creatinine clearance when it approaches 30 milliliters per minute. A lot of drugs can now not be filtered properly, and we have to change the doses of drugs. So you can see that a normal creatinine clearance is very far away than 30 milliliters per minute, which is really poorly functioning kidneys. Okay, so a creatinine clearance we can use a serum creatinine to calculate creatinine clearance, which is our kind of calculation of GFR, or we can do a 24-hour urine test where we have someone urinate into a bucket for 24 hours and we see how much creatinine they're clearing in 24 hours. Okay, so those are the two ways of getting a creatinine clearance. Obviously, the blood test is a much easier way than doing a 24-hour urine test. Okay, so let's look at the final product of what the kidneys make, urine, right? So a urinalysis can test for many, many things. We can check for the color, right? So urine should typically be yellow. We can check for clarity, meaning is it cloudy, which might indicate a urine infection, or is it clear? We can check for pH. We don't often do that, but we can check for pH. We will get a pH value. Specific gravity tells us how concentrated is the urine. So if we find that the urine is very, very concentrated with a high specific gravity, it usually means that all the fluid is being reabsorbed into the bloodstream from the kidney because the patient's dehydrated, for example. You shouldn't have any glucose in your urine. That should all get reabsorbed back into the bloodstream. You shouldn't have any ketones in your urine. Nitrates are a byproduct of bacteria or bacterial metabolism in the urine. So if you have a positive nitrate, that's often an indicator of a bacterial infection in the urine. Leukocyte esterase, that's an enzyme that we can pick up in the urine, and you shouldn't have any either. And if you do, it's another strong indicator that there is a bacterial infection in the urine, either a bladder infection or a kidney infection. You shouldn't have any white blood cells or red blood cells because they shouldn't be getting through the glomerulus, right? Cells and proteins, for that matter, should not be getting through the glomerulus and ending up in the urine. And CAS are basically cells that have gotten through the glomerulus and gotten stuck in the nephron because they were never supposed to get through in the first place. And they basically made a mold of the inside of the nephron and then let go and ended up in the urine. So if we see casts in the urine, either red blood cell casts, if the cells that made up the cast were red blood cells, or white blood cell casts, if we see those, we know the problem is coming from the kidney, because the only place where you can make a cast, which is basically the inside shape of a nephron, is in the kidney. Okay, so let's go through this slide. Abnormal urinalysis. So the color, so the darker the urine, typically the more concentrated it is, right? The higher the specific gravity. And it's often an indicator of hypovolemia, which can be hypotension, low blood pressure, or dehydration. Now you're going to come across many medications that change the color of your urine. So you'll probably hear of a medication called phenazopyridine, which is a medication that numbs your bladder wall in urinary tract infections. Rifampin, which is used for tuberculosis, can change the color of your urine. So there's a number of medications that change urine color. Specific gravity, that's telling you how concentrated the urine is, right? High specific gravity, very concentrated. Low specific gravity, very dilute urine. Glucose, you shouldn't really have any glucose in your urine since it's all reabsorbed. But if you go beyond a threshold in the serum of 180, then typically the nephrons aren't able to reabsorb all of the glucose and it spills into your urine. Okay, so if we see glucose in the urine, what are we going to do? We're going to do a glucometer, a finger stick glucose, to see what the serum glucose is. Ketones, typically there shouldn't be any, but they can be positive in the setting of dehydration, because in dehydration you start to get acidotic, or they can be positive in the setting of diabetic ketoacidosis, where you're making ketones because of the lack of insulin. Nitrates, they're an indication of a bacterial infection if they're positive. Leukocyte esterase, if it's positive, an indication of bacterial infection. White blood cells and red blood cells, again, are another indication that there's likely an infection in an area of the urinary system, whether the bladder or the kidney. Red blood cells, if you're having a lot of pain, especially flank pain, when we see red blood cells in the urine, that often goes along with the passage of a kidney stone. Okay? Proteins, they're usually an indicator that large proteins are getting across the glomerulus and into the nephron, and that's a problem. So that's an indicator of some kind of kidney disease. And casts, for sure, are an indicator of renal disease, and it usually means that you're leaking red blood cells or white blood cells into the nephrons that are becoming molds of the nephron and then break off and go into the urine. Okay, so here's a lovely image of how a cast is formed, right? So the glomerulus should never allow white blood cells or red blood cells or protein to go across. But if they do go across the glomerulus, they can make white blood cell casts, red blood cell casts, or even protein casts. And once they clog up the nephron, some of them finally break off and end up in your urine. And they're an absolute indication that there's something happening in the kidney that are forming these casts. Okay? And we'll talk about some of those conditions coming up. Okay, so let's just do this slide together. What changes would you expect in a patient that's experiencing a decrease in GFR? So a decrease in glomerular filtration rate means a weakening kidney, right? So as it descends from a normal of approximately 120, as it goes lower and lower, 80, 60, 50, 40, 30, your kidneys are able to filter less and less. It's an indication of chronic renal disease. So you will make less urine, right? So will you make an increase or a decrease in urine output? A decrease in urine output, because your kidneys are able to filter less and less. Are you potentially going to have hypervolemia or hypovolemia? Well, you're likely going to become volume overloaded as your kidneys are able to filter less and less, to the point of needing dialysis, say, where you just don't filter at all, and you're not making any urine. So in that And hypervolemia is a risk factor for severe kidney disease because you're not able to clear um, and control the plasma volume, right? Increase serum creatinine and BUN or decreasing serum creatinine and BUN. So it'll be an increase in serum creatinine and BUN as your glomerular filtration rate and as your kidneys weaken. Your creatinine and BUN will go higher and higher, right? Hyperkalemia or hypokalemia. Definitely hyperkalemia is a risk factor in the setting of chronic renal failure because you're not able to secrete your potassium, right? So potassium comes from cellular breakdown, which is happening all the time in our bodies, right? So we need to have a way of clearing potassium. And if the kidneys are getting weaker and weaker and weaker, potassium is going to build up in the bloodstream and you're at risk for hyperkalemia. Hyperphosphatemia and hypokalemia, or hypophosphatemia and hyperkalemia. So what do the kidneys produce that's needed for calcium metabolism? Well, they activate vitamin D that comes from the skin. And since you're not making vitamin D, or active vitamin D, you're not absorbing calcium. So you're going to be hypocalcemic. When you're hypocalcemic, your parathyroid hormone is secreted more and more and more because it's trying to get your calcium levels higher. And in the process, it's stimulating the bone to break down and releasing phosphate into the bloodstream. So you're going to be hyperphosphatemic and hypocalcemic. Let's do one more that's not on here. Acidotic or alkalotic. Well, if your kidneys are failing and getting weaker and weaker, you're not able to clear out your H+ ions in your kidney, and you're going to become acidotic. Okay? So all those are signs or blood values of what happens as your kidneys get weaker and weaker and weaker. And we can do another one. As your GFR declines, are you going to develop anemia? Yes, right? You're not making erythropoietin, so you'll become anemic. Are you going to have poor wound healing? Yes, you're not secreting your waste products. You're not clearing all the waste, and the wounds won't heal as well because of the waste circulating in the bloodstream. Okay, so when we're talking about the glomerular capillary membrane, it's the place where the capillary meet the glomerulus, right? So, and there's about 1 million of them in each kidney, right? Since there's 1 million nephrons. And what goes across the glomerular capillary membrane naturally or normally? Well, water, your electrolytes such as sodium, chloride, potassium, magnesium, they all go across. They're tiny. Glucose goes across, amino acids go across, your waste products go across. They all leave the blood and become filtrate in the nephrons. And then, of course, as all of this goes through the nephrons, there's going to be a lot of reabsorption of the molecules in the water that the body wants to keep, right? So even though it left the glomerulus, the body can easily reabsorb what it wants to keep. So if it wants more sodium, it'll reabsorb the sodium. If it wants more fluid, it'll reabsorb the water. It definitely doesn't want to get rid of glucose, so it's going to try and reabsorb the glucose and, of course, the amino acids, but not reabsorb the waste. So large particles, such as plasma proteins, blood cells, such as red blood cells, white blood cells, they never should leave the capillaries and go into the glomerulus. And they only do in the setting of disease. okay? They should always stay in the capillaries and then go um, uh, through the, they go into the glomerular apparatus, but they never leave the bloodstream, okay? They remain in the venules or the efferent arterioles that leave the glomerulus. Okay, so the glomerular capillary membrane is semi-permeable. It allows many things across that are typically small in size, and it stops large particles from going across into the nephron. So here's a video on the glomerular capillary membrane. And by the way, this particular company, Osmosis, has some really fantastic books on pathophysiology, anatomy, all kinds of really interesting books that are concise. Okay, so let's talk about some glomerular disorders. So these are diseases that will harm that capillary glomerular membrane, okay? And is going to result in a number of symptoms because of the injury that occurs at the proximal nephron called the glomerulus. Okay, so when we talk about primary glomerular injury, we're referring to disorders that are directly harming the kidney or the glomerulus as the primary disease. Okay, so whether it's an autoimmune disease that's attacking the glomerulus, or it's drugs that are harming the glomerulus, or toxins that are in the bloodstream, or even an infection that we'll talk about that is directly harming the glomerular area, that will be called a primary glomerular injury. Okay, a secondary glomerular injury is due to a systemic disease that happens to be also injuring the kidneys. And diabetes mellitus is definitely a disease that harms the capillaries and the glomerulus, and leads to a number of renal issues, including renal failure. Hypertension also injures the blood vessels because of the high pressure in them, so it injures the blood vessels within the kidney and can lead to renal failure. And lupus, which is an autoimmune disease that is systemic. It's all over the body. It affects many, many organs in the body, but also it impacts the glomerulus. Okay, so a primary glomerular injury we think of as a disease or a process where the primary issue is the glomerulus. A secondary glomerular injury is there's a disease process happening in the body, and as a secondary complication, we now have glomerular injury. Okay, so let's talk about acute glomerulonephritis. And there's many conditions that can lead to glomerulonephritis. And as the term implies or refers to, it's inflammation, nephritis, involving the glomerulus, right? So anything that injures the glomerulus and inflames it can lead to this condition. And we'll talk about some conditions that cause this. So just understand what glomerulonephritis is. So typically, it is a condition where either antibodies attack the glomerulus and cause inflammation of the glomerulus, or there's some kind of circulating antibody antigen complex, and we're going to talk about strep throat glomerulonephritis in this case. So there's an antibody antigen complex that's circulating in the bloodstream, and it clogs up the glomerulus. Okay, so when we're talking about post-streptococcal glomerulonephritis, so after a strep throat, you have antibodies that are produced, and the antibody complex, the antibody and the antigen, damage the glomerulus and cause inflammation and decreased filtration through the glomerulus because it's so swollen. And you can imagine this is happening in millions of nephrons. Okay, so because glomerulonephritis is always an inflammatory condition, you're going to get damage to the glomerulus. Okay, so let's look at some of the symptoms and signs of glomerulonephritis. Well, if we go right to the bottom on the right, look what's happening in the urine. So because the glomerulus is injured, it's leaky. So now proteins are going across it. White blood cells are going across it. Red blood cells are going across it. So all of those cells and proteins that weren't leaky and going across the glomerulus before can now go into the nephron and leak into the urine. Okay. Now you can have oliguria. So oliguria means decreased urine production if you have glomerulonephritis, because the glomeruli aren't able to filter as much because they're inflamed. Okay, so this is a condition where you can get, say for example, red blood cell casts or white blood cell casts, because those cells are able to leak into the nephron and produce those casts that we spoke about. Okay, well, you gain weight because your kidneys aren't working very well, so you can't regulate your plasma volume and your tissue fluid. So you get edema. Okay, so these patients often have swelling of their legs, swelling around their eyes. Okay, if it's from streptococcal or post-streptococcal glomerulonephritis, they may have a history of a sore throat 2 or 3 or 4 weeks ago, followed by these changes. So they may have a low-grade fever. And any glomerulonephritis, since it's inflammation, you could have a low-grade fever. Fatigue, because the waste products aren't being cleared. So your creatinine is going to be elevated. Your BUN is going to be elevated in your bloodstream. Hypertension, because the kidneys regulate blood pressure and they regulate volume status. And because the kidneys are inflamed right now, you have hypertension, which is then leading to a headache. So all of these symptoms can be explained, and what we find in the urine can be explained. Okay? So this would basically apply to any glomerulonephritis, but we're going to talk about one that happens after having a strep throat. Okay, so when you have a strep throat, you have Streptococcus A growing in your throat, and you can actually have an immune response to the strep throat, right? So you form antibodies, and those antibodies can attach to antigens in the glomerulus and form antibody-antigen complexes. And if you can imagine these floating complexes that are just clogging up all the glomeruli, that's what's happening, right? So they're inflaming the glomerulus, and they're blocking the nephrons. So this can happen after having had a strep throat. Okay, so the basement membrane, which is typically not permeable to proteins and white blood cells and red blood cells, has now become permeable to them. Okay, and also the basement membrane is inflamed. So what are the signs and symptoms? Well, you're not making as much urine because your kidneys are having an acute kidney injury. Okay, so the glomeruli aren't able to filter as much. So oliguria is usually a term reserved for less than 400 milliliters in a 24-hour period. You have proteinuria because proteins are leaking across the basement membrane in the glomeruli. You have edema because you're losing albumin as part of those proteins that are going into the urine, and you also are retaining fluid because the kidneys are unable to regulate fluid balance in the body. Okay, so edema is happening for two reasons. You're losing protein. Well, that's going to lose your oncotic pressure, and you'll get edema. And the kidneys aren't functioning properly, and they're failing, so they're not able to regulate fluid balance. The cola-colored urine is basically just blood that's going across the glomerulus, and because the glomerulus is also inflamed, it's going to leak blood into the nephron, which is then going to be seen in the urine.